Yeah, you guys see my screen?
Yep.
So I saw this today. It's kind of interesting, and I'm curious because just want everyone's thoughts. This was being done just to evaluate her lungs. She's an inpatient, has been here for a month, and I don't think there's much exciting going on here. She's got some edema with or without some, she's got some central lobular nodules. So with or without pneumonia or aspiration on top of that, and you can see she's got bad underlying emphysema. But it was actually when I was looking at the lung windows, I noticed this, and I don't know how well you can actually see it, but I was like, huh, that looks weird. And on soft tissue windows, this is fat in the pulmonary artery, and it's tubular, but it measures like between -60 and -80 Hounsfield units. And it goes from her right main PA into the lateral segment of her right middle lobe. And so sure enough, she's had 2 CTs. This was her presenting CT last month. So this was, I think, June 14th, June 15th. So exactly a month ago. And, this was there. It's the same attenuation then. It's called a PE, and I agree, except when you measure it, it's actually lower than that. So she's been anticoagulated for a month now for what was called a PE, but I don't know what to do about this because it's completely unchanged. And she did have some rib fractures. She was a trauma. I don't think it's fat emboli, because even the macroscopic fat emboli we've seen in the past have been more globular. I wonder if it could be, is it some sort of intravascular lipoma? Is it something that has embolized? She doesn't have fibroids. We've seen stuff like that before. I just don't know what to do, but I don't think she should be anticoagulated for this. And I'm curious what everyone else thinks, because she has had a GI bleed since she's been in the hospital because of her anticoagulation.
Is it branching at all?
I thought it was more just like kind of, here, I'll do a coronal on this. I thought it was more just kind of almost, adherent to the wall of that right there.
She had a PA catheter ever? Yeah,
I don't know. Probably, that's a good thought, probably, because she's had, she has had a prior sternotomy and has a non-union. This wasn't from this admission. And she has no prior imaging here, but
so it could be some kind of fibrin sheet, something like
that. Yeah.
Yeah, but I agree. I mean, that's not a thromboembolic event that requires anticoagulation.
Right.
So, and she doesn't have a kidney tumor like, and
no,
anything like that.
No.
Sorry,
David.
We had a case of I think it was an AML, angiomyolipoma, with an embolic component. So there was a well-defined fat structure in a pulmonary artery. It's been decades, so I'll have to go back and look up that case.
Yeah, I like the thought of maybe some prior indwelling catheter, but it's not. But even that, it's still lower attenuation than you would expect for a chronic fibrin sheath. But I don't know. I don't think she needs to be anticoagulated for this. So I was just curious if there were any other thoughts, but I like that. I'm going to show one more. This is an interesting one. And this is a patient who presented with SVC syndrome. And I think you can see why, that there's this relatively hypervascular mass that looks like, my guess was it was arising from the superior vena cava here. You can see it goes right down to just above the right atrium, even comes a little bit, I think, into the azygos arch, as you can see here. And sure, I think it's probably contiguous with this adjacent right paratracheal lymph node. And you can see the resultant collaterals from the compression of her superior vena cava and occlusion. And so presented with superior vena cava syndrome from this. And you can see there are a few nodes in the right supraclavicular region and bad emphysema, some mild granulomatous disease, but nothing else in the lungs, no other primaries. And does anybody want to venture a guess as to what this is, the pathology of this? Because I was surprised.
Well, if you're surprised, I'm not thinking sarcoma. Then how about a paraganglioma or something?
Paraganglioma,
Well, that was,
Castleman's disease.
yeah, those are things that wouldn't have surprised me as much either. This actually just turned out to be lung adenocarcinoma with no known primary based on the biopsy of these supraclavicular nodes. But I don't think I've ever seen it behave like that. And I'm wondering if they need to get more tissue. Because what's interesting, this is, there's one study here. Oh, maybe I don't have it. I thought there was a study from a few years ago that actually showed that this thing may have been there. And I guess I don't have those, but yeah, you can see it's pretty vascular. But yeah, all of those things we were thinking, some sort of sarcoma, some maybe Castleman's, maybe paraganglioma, weren't as, we were betting heavily on a sarcoma, and it just turned out to be metastatic lung adenocarcinoma. So, yeah. All right. Well, Jeff, I will stop there for now.
All right, thanks, Travis. Seth, are you ready yet? Or are you still working on it?
No, I can go. I'm just trying to get this. Let's see here.
Oh, it's a different one.
All right. Can you see this?
Yes.
Okay. So I have a whole MR, but it would be too painful to show given the speed of my VPN. So this is a 25-year-old guy from overseas who came in with chest pain and shortness of breath. And I've seen a lot of uncorrected congenital heart disease in some of our immigrant population, but this I had not seen before. So you can see, let me just get down the meat of this. I mean, I've seen this plenty of times, and I have much better images than this, but I'm not going to spend the time looking through the 5000 series. You can see there's a VSD here. You can also see that there is a single outflow tract arising from both the kind of left ventricle and the right ventricle. Here's the left ventricle, is right ventricle. And if you follow that single outflow tract up, you'll see a big meaty, what looks like an aorta, and that aorta gives rise to a left pulmonary artery here, and also, so you can see coming down, and then there's also this right pulmonary artery here, and it's not really an aorta, it's just a combination of the two that are basically merged together. So this is an uncorrected truncus arteriosus in like a 25-year-old, 24, 25-year-old. It's a type 1 truncus. I was debating whether to be a type 1 or type 2. It's somewhere, type 1 is where you basically have a single branch coming off near the aortic roots, kind of ascending aorta, and that single branch kind of divides itself into the left and right pulmonary artery. So it's going to be this thing right here, and you can see it giving off the right here, and then I scroll up slowly or quickly. So there's, yeah, anyways, you guys get the idea. I'm sorry that this thing, here's the left PA here, here's the right PA, and it's coming from the aorta. So again, or from the posterior lateral wall of the aorta. I don't think I've seen an uncorrected truncus in an adult this age. I've seen it in like 5 or 6 year olds, but not someone this old. So that was an interesting case. And I apologize, I have really some pretty fascinating cases over the past 2 months I've been gone, but unfortunately they're hard to find from today for me, from working from home, because I don't have access to my shared drive where I keep all my cases. This is a case of a patient with, let me just do this in order, with polymyositis, dermatomyositis, who developed she was negative for COVID. Initially, I thought it was going to be COVID. So here she is, kind of her baseline fibrosis. You know, you can try to guess what pattern it's going to be. I mean, this is presumably somewhere in the range of healed DAD, multiple episodes of healed DAD. Maybe some people call it NSIP. It's really hard to know. And then anyway, she had another episode of diffuse alveolar damage, which is commonly seen in these patients with dermatomyositis. And she's been in the hospital for a while. She's on the transplant list. But the impressive thing is here is the amount of pulmonary interstitial emphysema. I don't think I've seen this much pulmonary interstitial emphysema before. I really thought that was pretty impressive. And you almost, you know, again, she's on the transplant list. You almost wonder if she's, whenever I see this much air in the anterior mediastinum and this much displacement posteriorly, I always get worried about some tension phenomena on the right ventricle. I mean, that's hard to show. I mean, there is some compression on the right ventricle, but it wasn't on echo. There was nothing there in terms of tamponade. I have seen cases of really bad pneumomediastinum caused tamponade before, but anyways, really impressive pulmonary interstitial emphysema.
Beth, was she on any like pressure support or anything for like breathing, or is it all room air?
You know, let me check.
See a nasal cannula.
Yeah, I don't see much in terms of a trach. So,
or a mask or anything. It looks just like a nasal. Okay.
Yeah, I mean, I would have to go back and look at her chest X-rays. I don't, even when she was starting to go downhill, I don't remember her ever having or being intubated. She was actually sent here, I think, from Irvine as a stat transfer for lung transplant. But yeah, I don't know. It doesn't look like it was barotrauma. This is just impressive. I mean, we've all seen these before, but this is just one of the bigger ones I've seen. So this is a bad trauma, motor vehicle collision, lots of badness in the chest, lots of badness in the belly. Aorta is actually fine, surprisingly. But the impressive thing here is this absolutely massive pseudoaneurysm with fistula formation between the right axillary / subclavian artery and the vein. So you can see here's the venous drainage, this big conglomerate goomba. And if you follow, see if I can do this without turning the whole screen black. And if you follow the artery out, you'll see that the artery also connects with this horrible mess somewhere out here. And there it is, kind of connects to this horrible mess. And then here's just an IR image nicely showing, if I can get it to play, which of course I cannot. There we go. So you can very nicely see the arterial injection, quick filling of this thing from the subclavian artery and then draining via the subclavian vein into the brachiocephalic vein into the SVC. So
was there an adjacent bone fracture or something like that?
Yeah, you know, it's interesting, Dave. You know, I didn't, someone sent this to me, or one of my colleagues said, hey, take a look at this. I looked, he definitely had some adjacent fractures, but there was not some huge, I mean, he had like a very subtle posterior fracture of the, or fracture of the T1, or sorry, the right posterior first rib adjacent to there, but he has a lot of bleeding in the chest, but I didn't see, and again, I didn't look that closely because I just assumed there was a major fracture somewhere, but there didn't seem like there's a little fracture here of this rib. I didn't see some massively displaced, you know, there's a little fracture here. I didn't see some massively displaced, you know, clavicular fracture or rib fracture or other bony fracture that was, you know, had a sharp protruding edge that was clearly lacerating the vessel, but I assume it has to be there somewhere. I just didn't spend the time to look at it. But you know, even looking at it in retrospect, I really didn't see much there. And this wasn't a, you know, he might have had some, he has some error here. Maybe there was some penetrating trauma associated with the motor vehicle collision. I would have to do a better history with that one. I just thought that was impressive. And then this is, you know, I talked about multiple times here that, you know, we have a weekly CTEF conference, and this was the last one I was at, and this patient was sent here from quote unquote outside institution with chronic thromboembolic disease, and I just shocked all the time. Clearly, you shouldn't see contrast going from the right atrium into the left atrium at any point in time, which wasn't commented on, nor should you see a big PAPVR. So this is, you know, within, I think most of us within a few seconds have recognized this is a PAPVR with a sinus venosus ASD, and there is, of course, a large lining thrombus that is going to be not PE, but rated, you know, mural thrombus related to the patient's severe pulmonary hypertension and Eisenmenger syndrome. And you can actually nicely tell the patient has Eisenmenger's because normally right atrial flow does not go into the left atrium flow goes into the right atrium. So you're even seeing the Eisenmenger's physiology on this study. But I was really shocked when I saw this, because I couldn't believe that this wasn't even mentioned. They just called it chronic PE and sent it to us for therapy. But just an impressive case of sinus venosus PAPVR with Eisenmenger's and nice lining thrombus. I always find it difficult to differentiate, in definitely some cases with bad PAH, to differentiate you know, mural thrombus in some cases from CTEF, especially in some cases where it's occlusive. In most cases it's not occlusive. Calcification is a good clue. I mean, chronic clot can calcify, but not to this extent. And you know, again, not a lot of obstruction, but there are some cases that are obstructed. So I thought that was a nice example of Eisenmenger's in that case. All right, that's it.
Thanks, Seth. Those were great. All right, we got Brian, David, and Peter.
I've got a couple, Jeff.
All right.
So I hope people can see a PHS radiograph here with what appears to be interstitial abnormality here, maybe some big nodules in this right lung apex. But if we move the image around, you can see that there's all this hair artifact in the neck, and it's really the hair that's overlapping the right upper lung that causes this interstitial abnormality. It's really a fake of the overlying hair, and on lateral view, there's just no evidence of there being anything inside the lung at all. So, you know, I've seen similar cases like this where it was really bilateral, and I tried to palm it off on the medical student, you know, introduction to radiology course by saying that this was such aggressive interstitial lung disease that it extended upward into the neck. Tried to, you know, put the cart before the horse, and that causes some consternation, but it's always fun. So pseudo interstitial lung disease here. And then I'd like to show you this, this case of these very fine calcifications here at the left base, kind of an arcuate pattern here. And it turns out there's a little bit of the same going on the other side. You can see a little bit of that bright stuff out here too. And this is also a fake. So showing you two artifacts, there's nothing on lateral view here, but if you look, if you open up the window, you see that these arcs of white stuff are external, and this is either talc or deodorant containing aluminum in this fold underneath the pectoral flab here. So this is overlying mineral here. I think it's probably talc, but sometimes aluminum in deodorants can do this. So I've seen the aluminum stuff in axillae before, and it can be in this intertriginous region here too. So overlying fake outs ×2. And then this is a woman who had intermittent chest pain that was tied to her menses and had hemoptysis on a few episodes. And chest radiograph doesn't show anything here, but CT around this time did show this ground glass abnormality in the anterior aspect of the right upper lobe. The person had bronchoscopy and they identified blood coming from the right upper lobe. They did not see any lesions in the airway, and this is considered to be catamenial hemoptysis and pulmonary hemorrhage. There's a little, maybe a little cyst developing in that. So catamenial hemorrhage here, hemoptysis, and it's presumed to be due to endometriosis, but they don't really identify, they couldn't identify any deposits. And so we don't have any follow-up really past this, this older imaging. And then this person was referred from the eye clinic because of uveitis. And it's a 35-year-old, roughly, man here. And he's got this mild interstitial abnormality and a little bit of thickening of the minor fissure here, but it's very subtle. So this was looked at by a different radiologist who wondered whether he was really seeing something or there was just, you know, an artifact of technique or something like that. But on CT, it's definitely there. And it turns out to be a very fine nodular pattern here. And you can see why the fissure was thick, because a lot of these nodules are clustered along the fissure. The interesting thing is that although we have them along the fissure, we have actually very few that are along these external pleural surfaces. But everybody's first consideration here is probably sarcoid, and that's a great cause of uveitis. So I've seen this on a couple of these multiple referrals we get from the ophthalmology clinic. When they see uveitis, they get screening chest radiographs. This is one of the few that actually turned out to have something visible. And this was, for one, let me show you the, first of all, on exploration, that there's no air trapping. We have seen some sarcoid cases that do have air trapping. And the MIPS are pretty impressive here in bringing out these nodules. It just has this busy look here. It actually looks more central lobular. And it's hard to see on these MIPS, the concentration along the fissures. That actually shows up better on the non-MIPS thin slices. So this was proved to be sarcoidosis on transbronchial biopsy. There were non-caseating granulomas, no organisms. So diagnosis of sarcoid from the eye clinic. And then this woman has this very dense lesion here, and it looks as if it's at the level of the hilum, but it turns out it's way posterior. It's back here in the chest wall. And it's this bony abnormality here. You can see there's expansion and bone, and there's this dense sort of cap on this thing, and this was resected. And this was an osteochondroma. And this woman has multiple hereditary exostoses. If we go back to the chest radiograph, there's actually a subtle second lesion here projected in the right axilla, and on CT, that is this scapular lesion here, which was also resected and was an osteochondroma. And there are lesions elsewhere. Let me show you the pelvis. So this lesion had been resected in years past, this big pelvic exostosis here. Again, another osteochondroma. So cartilaginous tumor with this nice cap on it. And then there's deformity here of the proximal femur is also osteochondroma. You can see it pointing off in this direction, overlapped by the pelvic abnormality. So multiple hereditary exostoses. You can see the deformity of the other femoral neck on the other side. This is not a normal femoral neck. That reflects this growth disturbance. So this woman, I think, is in her late 30s or early 40s and continues to have, symptoms from these lesions. They're supposed to stabilize once somatic growth has been finished. But her lesions have required recent resections because of symptoms. And there is a risk of malignant degeneration of this, so multiple hereditary exostoses. Okay, that's all I had.
All right, thanks, David. So on your sarcoid case, I think that's a nice example of what's sometimes called miliary sarcoid, but it's not a true random distribution, as you showed, that you can see the perilymphatic portions of it, but it's just not as striking as some other cases. And I'm glad you showed the hair artifact, because I've seen cases mimicking the same thing, as well as ponytail knots mimicking lung nodules.
Yes.
And so
Indeed.
It's always worth getting a two-view chest or repeating something before, especially in a younger person or it just doesn't quite fit, before sending them for an expensive, unnecessary CT.
And look at the neck too. So.
All right, who'd like to go next? We got Peter and Brian.
I can go. So this case is a patient in her 80s, and I'll show the X-ray. So this is an X-ray. So you see diffuse consolidation, and here's her chest CT.
Were you saying something?
So this is just a nice case of diffuse adenocarcinoma.
Thanks, sir.
So I thought this case might be a good kind of, could be a fake out for some systemic disease. But it's just a nice case of widespread adenocarcinoma.
Is it lung primary?
Lung primary, yep. And then just a PET CT. Let's see, this one was interesting too. This patient is a 50-year-old patient. Start off with the So this is the prior scan. 50-year-old patient. About 2 weeks ago, week and a half ago, he came in with renal failure and at an outside hospital. He was biopsied and had post-immune glomerulonephritis. And then a few days after that, he was short of breath, had some hemoptysis, and this is his CT that he came in with. So new nodularity, as you can see, ground glass. It looks kind of like tree and bud in some places. But he was bronch and he had DAH. And so they got labs on him, ANCA positive, NPO positive. So this is a case of ANCA associated vasculitis, most likely microscopic polyangiitis. Use NPO positive.
That's impressive. More often you see either hemorrhage or sometimes a little bit of fibrosis, but this is, unless it's all just sort of subacute hemorrhage there.
Yeah, but I'm assuming the ground glass is subacute hemorrhage.
The sort of branching nodules is a little bit odd. Maybe it's at the arteriolar level or something, but it usually causes capillaritis and not larger vessel involvement. That's interesting.
And then the rheumatologists are not. I spoke with them on the phone. They think it's probably microscopic polyant, but they're still calling it officially ANCA-associated vasculitis, and it's essentially the same management as GPA, which would be the other differential. But this fits more with microscopic, based on all the lab findings.
No, I noticed he had a mechanical aortic valve, so I presume he's anticoagulated. I wonder if that.
Yeah, exactly. So that might have contributed to the DAH. They had a bicuspid valve replaced with mechanical valve, and yeah, he is on anticoagulation. Yep. This is just a quick example of a case of a cardiac MR sub-aortic membrane, and it's actually not the easiest to see, but I'm just showing it anyway. So you can see these. There's a little sub-aortic membrane here, and you can see this flow acceleration here, which is proximal to the sinus of Valsalva. Try to see it right there. Also, you can see the sub-aortic membrane a little bit right there. Just a nice example of that. This was a good case for newer residents. So this patient had acute chest pain, and I should have included the non-con also, but this is a nice example of an intramural hematoma with a associated hemopericardium. And one of our residents on call was actually a pretty impressive call. She also noticed this posterior irregularity there on the aorta, and so that's basically the intimal, the entry tear right there. So she pointed that out, which I thought was a pretty good call. And so this was, they had their ascending aorta was replaced.
Peter, was that just done as an aortic scan or as a PE study?
It was a dissection protocol.
Okay. Do you normally do a non-contrast with it?
We do, yeah. I just forgot. I didn't send the. I didn't send it to Osiris.
Yeah. I feel like we pick up more dissections on PE studies than on dissection studies.
Oh.
But
Yeah,
I was just curious because we don't routine, because those aren't gated. We don't do a non-contrast.
Yeah. Yeah, it's actually, yeah, it's hard to appreciate the intramural hematoma on this one without the non-con actually. But there's a little bit so if you didn't have the non-con, you would question there's a crescent there, but it's much easier to see. It was much easier to see on the non-con. Should have included that. Okay. A few more quick ones here. Oh, this one is one of Dr. Stillman's cases he showed me. I thought it was very interesting also. So abnormal chest radiograph, and the abnormality is right here. And so here is we didn't have a recent CT, but we have an older CT from a few years ago. So here's what that is. Pull up the X-ray also. So it's a giant left atrial appendage. And this was, at the time, I was looking at the cardiology notes, and this was read a few years ago. This is a left atrial appendage aneurysm.
What causes those?
I don't know. They at the time when I was looking back at the notes, they thought they just presumed it was congenital and had her placed. They had the patient on prophylactic anticoagulation.
So it's not a it's not a pericardial defect, is it?
No, we couldn't. No, we didn't see a pericardial defect there.
I've never seen that. That's weird.
I hadn't either.
Can you give us a coronal?
Yeah. Let me just.
Sagittal may be nice too. Yeah.
I guess it's not. I didn't have the thinnest section, so it's not a good reconstruction. But it's right there. Let's see how it looks on the sagittal. And I wasn't sure if this is thrombus, and it was in the Hounsfield units in the 50s. But regardless, they put her on anticoagulation. This was 2017. And then
They're saying, I'm just looking at it, they're just saying it's congenital.
and then 2 quick cases of one of this entity of mitral annular disjunction. So so that's basically this is defining 2 cases of this that showed up within a month, but basically it's a atrial displacement of the hinge point of the mitral valve. So you can see this gap right there. It's probably best seen on 3-chamber views. So that's one patient. It's the same patient. So you can see this gap right there. And then the other patient, the same finding. So again, right there in the posterior membrane, and here's a article on this entity.
So does it create a channel that the blood can flow in, or is it just an abnormal location of an
It's
attack?
just an abnormal location, and they've recently done studies. So it was identified. I recently started hearing about it, but it was identified apparently about 20 years ago, 20, 30 years ago, but they recently did studies that shows that it's associated with, there's some association with sudden cardiac death and arrhythmias.
Yeah, I mean, it's similar. It would be interesting. I don't know. I read this study. I can't remember the points, but we see a lot of people with quote unquote, Barlow's disease or really bad posterior mitral valve prolapse. And those are also associated with sudden cardiac as well. So I can't remember. I think they showed that there was an increase, even based on that, there was even an increased incidence of this when you had this compared to those with mitral valve prolapse. I can't remember, but both are associated with arrhythmias and sudden cardiac death.
Right. Yeah. Exactly. Both are.
I mean, it's funny. I went back. I saved cases of bad mitral valve prolapse for MR, and before I from the last 10 years, I went back and a lot of them had this. I just didn't even know what this was. I never heard of it before a year ago.
Yeah.
And they were all bad people with bad prolapse, and they all had arrhythmias, and they had mitral annuloplasties to fix it. And so, yeah, it's interesting. We just had a case last week too. It's a interesting thing.
Yeah, I'm looking a lot more for it now, but yeah. That's all I have.
Great, thank you. All right, Brian, you have any cases this week?
Sure, I can share one.
All right, Mr. Presenter.
All right, so this is a middle-aged woman with presenting with a non-ST segment elevation myocardial infarction. This is an image from her coronary cath. You can see here's the LED with the septal perforators, and then here's the left circumflex, and here's the first obtuse marginal branch, which kind of just dead ends here. So this was called likely SCAD, spontaneous coronary artery dissection. You can see here's that vessel again on the orthogonal view, just kind of dead ends right there, consistent with SCAD. So we see this occasionally, and a lot of times the providers will order a additional CTA imaging to look for additional sites of aneurysms or dissections. There's an association with fibromuscular dysplasia. And just interestingly, pretty straightforward, you can see there's this area of regional hypoperfusion or hypoenhancement involving the lateral left ventricle wall, fairly well demarcated. Doesn't appear to involve the entirety of the base or the apex, seems somewhat confined. Here's a short axis reconstruction showing that same thing. It's a subendocardial in distribution. Here it starts not really present so much at the base, but more prevalent at the mid chamber, and then the apex is relatively preserved. And then here's a 3-chamber kind of showing the same thing. And then just as a twofer, she also had a anomalous right upper lobe partial pulmonary venous return, which you can see here draining to the SVC. And you can see that here on the axial as well. That's it.
Why do they call, I mean, I've seen a lot of scads on cath. Usually they're not abrupt occlusions. Usually look like just thinning, long segment thinning of the vessel. I mean, It looks like the vessel all of a sudden becomes narrow. It doesn't, I'm just curious. I mean, and I'm looking online because I've seen a lot of these cases, and you know, usually it just looks like in a young patient, like, I don't know if I can share my, I mean, this is what I'm looking at, like every, I don't know, I can't show my screen, but if you just,
you can share it if you want, that's fine with me.
Sorry.
Yeah.
Sorry, I'm just looking at, but this is what I associate with every case of SCAD I've seen, where you just have long segment thinning, or even potentially a dissection flap. That's every case I'm seeing online. So I'm just curious. I mean, it may be a dissection, but I don't know. Has anyone else seen a SCAD case look like an abrupt occlusion? Anyone who
It almost
does?
more looks like an embolic thrombus, but I'm not an expert on coronary, so.
Yeah, no, that's what I was thinking when you first showed it. And
Interesting.
I don't know a ton of SCAD. I mean, I have, you know, seen about 10 cases, and I've written some articles on it, like review articles, and I just never seen case with an abrupt occlusion. I mean, I'm sure it happens. I've just never seen that. So I'm just.
Yeah, it could be. Yeah, that's the way it's built to me, but yeah, that could totally be. Yeah.
Anyways.
Yeah. Yeah, they called it a type 1 SCAD lesion, whatever that means. I don't know.
Yeah, there's 4.
All right. Well, thanks. I'm going to move over here away from the noisy bird. Okay, so this is an interesting case. So this is a woman who presented way back when with a cough and fever, and she has this sort of mass-like area here on her chest radiograph, some ill-defined consolidation, maybe a little bit on the left there. And then at the time, she's a diabetic, had some mild kidney disease at the time, and had previous heart surgery. And you can see on the CT, she's got this dense consolidation and some nodules. Looks like any other infection, pleural effusion, some lymphadenopathy. I should add, she's got this sort of peripheral, bilateral lymphadenopathy with peripheral calcification. So that's consistent with more remote sarcoid. So she has a history of sarcoid, but that predates all of this. So it looks like community-acquired pneumonia didn't get better with, routine antibiotics. So ultimately was ultimately diagnosed with histoplasmosis. So this is an uncommon case of acute histoplasmosis actually causing symptomatic disease. And so it can present as consolidation, and they occasionally have pleural effusion. It's not very common, but they often have some lymphadenopathy, although I chalk most of hers up to sarcoid. But what's interesting about it is, so she got better, no problem, and then shows up about, about 8 years later. She's now developed more advanced kidney disease, and you can see pleural effusion. And what's left of that is a nice example of a histoplasmoma. So it's this calcified nodule or peripherally calcified nodule in the right upper lobe, and you can see there's some satellites nearby, which we see. I must have a hotkey here that I'm bumping. There we go. But satellite nodules, which we do see on occasion with some histo nodules. And then what happened is, so she was being worked up for a kidney transplant, and so this is her most recent scan. And interestingly, that cavity has that nodule has cavitated, and it's got some nodules adherent to the wall, so whatever was in it spilled out. So I presume what happened somewhere between these two scans, which occurred over about 2 years, is she actually reactivated her histoplasmosis because normally these organisms are just contained by granulomatous inflammation and they sort of lie dormant. But in a small number of patients, particularly those who have immune dysfunction and with her chronic kidney disease and diabetes, she has some defective T cell function. She probably reactivated at some point, and this underwent liquefaction, necrosis, and then did whatever, but it was probably subclinical at the time because I couldn't find any documentation of a respiratory illness. And this came to my attention because of her transplant workup with what was this cavity, and working backwards, was able to sort of sort this all out, but not something I've seen very often. I've seen a couple cases of reactivation histo where the histoplasmoma does cavitate, but never to one that presented with a primary infection like this. Okay, the next one I have is, this was a nice trauma case for a variety of reasons. So this was a motorcycle crash, and you can see there's a lot of chest wall injury. They've put a pleural drain in. We see a gastric tube that comes up high. And there was initially concern for a diaphragmatic rupture, as I think we would all be concerned for given the severity of the injury and the location. But on CT, we don't see a diaphragmatic injury. You'll notice that the crus is thinned, and we have an intact diaphragm all the way up. And so this is an eventration mimicking a diaphragmatic injury, and it turned out that she had had this for some time. A lot of our patients come in, we don't have all their records or their full name, so they come in unidentified. And you see there's some just collapsed lower lobe. But what else is kind of interesting is a less common injury that's very easy to overlook, and that's her left sternoclavicular joint. And you can see that there's gas around it, which there shouldn't be gas in the joint capsule, and the articulation is widened if you compare it to the other side here. So this is a sternoclavicular joint dislocation. It's usually posterior, and it can cause impingement on the brachiocephalic vein. In this case, it's more of a lateral disruption. So there's probably some intact fibers here, but it allowed the joint to widen. And then even her rib articulation here, the first rib cartilage, which is mostly ossified at this point, you can see the disruption in the articulation. So there must have been a direct blow to this region, either from a steering wheel or even a seat belt if it wasn't properly fit. So just an uncommon injury. She had scapular fractures, other things, but I like coronals for these sternoclavicular dislocations. It makes them a lot easier to see. She's very contorted, so it makes it a little bit more challenging, but you can see that widened joint there. If you can get them in the same plane, it makes it easier. So the clues are the gas around it, and then sort of this sort of the malalignment, and then the first rib articulation also being misaligned.
So Jeff?
Yes.
Can you give us a sagittal on that to look at the diaphragm?
Sure.
Because with eventration, there should be some, yeah. So you can see that anteriorly, there's good muscle thickness.
Yeah.
And then you have this thinning posteriorly. So that's great for eventration, say, rather than paralysis, where you'd expect that anterior muscle to be atrophied.
Right.
The way the atrophy. So I look at the crus for, eventration versus paralysis, but also on sagittal views, this anterior part of the diaphragm is a useful place to look for muscle thickness.
Thank you. Yeah, and also for disruption, it's often a lot easier to see the defect in it. Yeah, this one, because I think they were really worried about the diaphragm, but explaining them, showing the crus, and then just there was no defect, that this was just an event.
Yeah. The other thing, Jeff, you don't have an earlier CT when the diaphragm was not elevated, do you?
No. Because
I think that there's such a thing as acute eventration from stretching the diaphragm, but not actually tearing it to create a frank hernia, but just kind of stretching it to make it suddenly bigger than it was before. And in which case, you would be left with eventration because you've focally stretched that. I've seen some guys that fell off of mountains into chasms and stuff like that. People with bad falls and stuff like that. I've seen two of these people that had eventration afterwards, and I don't think they had eventration before, but I don't always have a lot of past imaging. So I think that there's such a thing as a stretched but not ruptured diaphragm that would leave you with eventration.
But
So
how would you, let's say this patient did come on with that history, when it's so thin up the top, how do
Right.
you know it's not torn? Is it just because it maintains that rounded configuration versus a more focal
And,
superior?
and you almost always see something poking through it. The fat will kind of poke through the.
That's what I'm saying. You don't see that kind of nice broad round, because to me, I can never see when it's this thin on CT. I can never see the actual muscle.
yeah, I think it's a good point. I mean, it's possible that what we're really seeing here is it is ruptured and we're seeing peritoneum, but it's just so smooth, and there's no sudden change in thickness. You know, it seems to just sort of taper, it fades into this thing.
And to
I have seen
point, you can see
that
how thin it is
because there was a sudden transition in thickness. You know, it was fairly thick, and then all at once it was thinner. I thought maybe that's a contained rupture. So I agree with you. I think it's important to look at that.
Mm-hmm.
The other thing that confuses it is that the lung can form atelectasis along these things when it's this elevated, and so sometimes what you think is tissue of diaphragm is actually just a band of atelectasis in the lung.
No, I struggle with these all the time. I mean, I just assume when it has this contour, it's event-rated, and if it was had a focal bulging, then it's
right.
You know, but I when it's this struggle.
They can be tough. Yeah, I agree sometimes, especially when you have enough trauma. But usually the ones I've seen, the diaphragmatic ruptures are associated with splenic or liver injuries and not higher up thoracic injuries. My sense from the CT was that most of the hold on, sorry, let me do this correctly. Most of the force was applied up here, where we see the scapular fracture and the dislocation, but it's hard to know when you don't know the whole mechanism.
So Jeff, was this a motorcycle or a car accident?
It was a motorcycle.
Motorcycle, okay. Because you mentioned steering wheel, so
oh
maybe
yeah, handlebar. Yeah, sorry. I was thinking sternal fractures in that. So this case is gotta remember which one this is. Let's see here. Let's see. Oh yeah, this is an interesting case, and Seth, you'll like this one. So this one was brought to my attention by one of our internal medicine residents. This is a young woman who is a former smoker, and she was recently pregnant at the time, and then during her pregnancy switched to e-cigarettes and had her baby no problem. But she presented with, she presented with acute respiratory illness at this time, very short period. And you can see she came into the emergency department, had pleural effusion, what looks like edema. She was intubated, underwent a CT angio. And as far as I know, she had no other medical history. And she's got this nice pattern of septal thickening, some patchy ground glass opacity that's sort of lobular, and these small layering pleural effusions. So it looks like a cardiogenic edema case, except she's young, has no heart disease. And so the only thing, again, with her history, she was a smoker but had recently switched to e-cigarettes. So intubated, was sent to the ICU, and on bronchoscopy and lavage was found to have multiple eosinophils in her BAL fluid. So it's consistent with an acute eosinophilic pneumonia. So she was started on high-dose steroids, and of course this responds rather quickly, and she was much better just days afterwards, extubated, and just a little bit of residual disease here. And what's interesting about this case is the only change was the transition to the e-cigarettes. And I know in our series we saw a few patients with an AEP-like picture, and we commented that we didn't necessarily have proof of it. But I wonder if this really is an E-volley that's manifesting as AEP.
Yeah, no, I mean, it definitely could be. I mean, it looks, I mean, when you showed the CT, I was thinking acute eosinophilic pneumonia given the normal heart, and then you said smoking. I said, oh, look at that. It's going to be that kind of pattern. But then to actually have the elevated eosinophils, I mean, this would be only the second case out there in the literature actually showing that.
Right.
I mean, it would make sense. I mean, it would make sense. It should do it. It's just, yeah.
So is edema something that points you to AEP? I would have thought it was not going to be, septal edema pattern. But is that
That's
characteristic?
yeah, that's the imaging pattern of AEP. It doesn't look like other eosinophilic pneumonias. It looks like edema. They have small effusions. I've seen a couple of other cases in young people, usually university students who started smoking, and we had one like back in 2010 or 11 that had very similar imaging, but she was breathing, so her scan's not as pretty. The literature has also described some consolidation in ground glass, but I think that's just all edema. But they're just usually very sick, but they respond so fast to steroids that most of them are extubated in hours to 24 hours at most, and are out of the hospital within a day or a couple of days because it just clears up.
Yeah, if I see someone with non-cardiogenic edema, this patient clear and without a brain injury, I always, something like this and some patchy ground glass, I throw acute eosinophilic pneumonia because I've seen it look exactly like this. I've seen it with more DAD-ish look, but with a lot of fluid on board. But yeah, they respond really quick. No, man, they didn't find any vitamin E or anything like that in the
No, not to my knowledge. And rapidly responded to steroids. And this case occurred during the fall pandemic. So this was during COVID too.
I've actually had 5 cases in the past. That's what I was looking for. I had a couple beautiful cases of Uveitis in the past 2.5 months.
Wow.
So with the more classic I'll try to, I have them on my workspace on my work, but yeah, I'm actually seeing more of it now than when the outbreak initially occurred. It's kind of probably just because
this would be the 5th case we had post since the pandemic. So when the CDC stopped reporting them, the Bali cases, and it was early February 2020. And then the pandemic was declared in March. So we had 14 cases at UW or so. This would be the 15th, and so a third of them occurred post-pandemic. So it hasn't gone away. I don't know if it's less common now, but it definitely is still out there and should be really in the differential of anyone presenting, particularly with an OP like unexplained OP.
Yeah, especially young kids. I mean, I just talked to, I was just lecturing at doing the ATS lecture on this with Brandon Larson, and he's still saying pathologically they're still seeing a lot of these biopsies of people coming in, young kids, and they have lungs are filled with acute lung injury and vitamin E, even though the acetate may not be the cause, but he's saying pathologically he's still seeing a fair amount of it too. So yeah.
Cool. All right, well, it is the top of the hour. Those were great cases this week. Thanks, everyone, and welcome back, Seth, and it was good to have everybody on. Howard said he'll be back next week, and I'll talk to you all later.
All right, take care.
Bye.
Thanks, everyone.